So the motto is revision is the great thing about revision is that it's an opportunity for us to fake brilliance. It actually makes us brilliant. So first we have is acute kidney injury, which is a 10 marker, will definitely come somewhere or the other, and you got to know goddamn things about it. Okay. So when you have acute kidney injury, what and all comes to my mind? Definition comes, the types come in that classification. I have KidGo classification, AKNIN classification, and rifle classification. Then I have etiology, renal, pre-renal, renal, post-renal. After that, I have in clinical symptoms evaluation, I have history, examination, kidney size, hematuria, volume depletion, all that stuff, and then functional excretion of sodium. Then in complications, I have hypervolemia, hyperkalemia, acidosis, uremia. Then in bleeding, hyperphosphatemia, cardiac complication, all that stuff. Then in prevention and treatment, I have urgent prevention treatment and subsequent this one. And we have indications of renal transplant therapy and management of each of those complications. That much comes to my mind, okay? So when we start with AKIN, definition, it is an abrupt distortion or disruption or abrupt deterioration or impairment in renal function, which is filtration and excretion, which causes a buildup of nitrogenous products, which in turn causes oliguria and which may be associated with oliguria and increase in serum creatinine levels and increases the risk of chronic kidney disease. Okay, what are the causes? What are the criteria of this one? We have KidGo classification, that is kidney disease improvement global outcomes. AKIN classification, acute kidney injury network classification, and we have rifle classification, that is renal failure, no, rifle risk, injury, failure, loss, end stage. I repeat, risk, injury, failure, loss, and end stage. Okay. So in KidGo classification, come on, bro. AKIN includes an increase in serum creatinine greater than okay. What is the definition in AKIN? What is the definition of acute kidney injury according to KidGo? Kidney disease improvement global outcomes. Okay. We have greater than 0.3 milligram per deciliter rise in 48 hours, or greater than 50% from baseline in 7 days. Okay. Can you repeat that? Greater than 0.3 milligram in 48 hours, or greater than 50% in 7 days. What are the stages? We have 4 stages. So what and all I can cover? I can cover acute kidney injury, chronic renal failure, nephrotic syndrome tomorrow. I can finish lupus nephritis. I can finish honeymoon cystitis. No idea what this shit is. Hematuria, yes. Routine urine examination, yes. Then I can do acute renal failure will be done there. End stage renal failure causes and all can do that. Renal osteodystrophy and do that. Renal replacement therapy very important. Hemodialysis important. Peritoneal dialysis, renal transplantation indication. Indication for renal transplantation, types of replacement therapy. Acute UTI. That is cystitis. About cystitis, we can talk upper tract, recurrent tract, acute pyelonephritis, reflex, impotence, sildenafil, chronic renal failure, 3 reversible factors of chronic renal failure. Uh, Reversible conditions such as, I think I mentioned here. See, these are things it should sort of correlate for you. So, what are the reversible causes of acute kidney injury? So, we have contraindications here, no? Contraindications. Reversible renal diseases. Okay, fine. I think this is an interesting question. I like to go to this. What are the reversible causes of chronic renal failure? Yeah. We have proliferative, not diabetes, no SLE, no gout, no chronic interstitial nephritis, no TB, the analgesic, yeah. Uh, Vasculitis, maybe. So, causes of reversible, this one, reversible factors, chronic renal failure. So, nice question actually. What are the reversible causes of chronic renal failure? Analgesics, definitely. Dehydration, NSAID, or this one. Infection, stone, analgesic, uh, dehydration. Okay. Okay, the causes we know. Okay, apart from the causes, let's see. I guess quite tensed, honestly, but I think it should be okay. Okay, so Kitgo classification. In this, we have stage 1, stage 2, stage 3. So remember, easy way to remember Akin and Kitgo. Akin is 1.5 times 1.5 to 2 to 2.2 to 2.9 greater than 3 times the baseline. Whereas over there in Akin it is 150 to 200. Same thing, 1.5 to 2, 2.2 to 200 to 300 greater than 300. Easy. In rifle we have 1.5 to 3, then need for RTT. Okay, simple. So let's go. In Kitgo classification, greater than 0.3 milligram per deciliter in 48 hours or greater than 50% in 7 days. In stage 1, we have greater than 0.3 milligram per deciliter in 48 hours or 1.5 to 1.9 times baseline creatinine. Okay, with less than 0.5 ml per kg per hour for 6 hours urine output. Now just write 0.5 ml per kg per hour. In stage 2, we have 2 to 2.9 times the baseline along with less than 0.5 ml per kg per hour. Stage 3, we have greater than 3 times baseline creatinine, less than 0.3 ml per kg per hour. So we have 6 hours, 12 hours, 24 hours. Done. Now Akin 150 to 200 times baseline, 200 to 300 times baseline, greater than 300 times baseline. Okay. So this one is done. Uh, the distinction between okay, rifle is to differentiate between acute or chronic kidney disease in cases of uremia. So this is over. Serum creatinine level not mentioned. Just serum creatinine criteria we've written. Proposed retrospective diagnosis and staging of AKI. Kitgo we have written. AKI not written like this. Okay, no problem. ADQ. There's something called stage 0 AKID, which is nothing but there's no evidence of injury, but this biomarker is available. Okay, that's all. Uh, so in rifle, yeah, risk, risk, injury, failure, loss, end stage disease. Risk. So in risk, we have 1.5 times the baseline in 48 hours. Injury greater than 2 times in is stage 2, greater than 2 times baseline. Failure is 1.5 times stage 2 times. Failure 3 times baseline creatinine. Loss is a persistent AKI requiring RTT for greater than 4 weeks, greater than 3 months. Okay, requiring RTT. So this is the staging. Next we go to etiology. So in etiology of AKIN, we have, sorry, let me just go to this. Yeah. So in etiology of AKIN, we have pre-renal, renal, post-renal. See, we won't have a lot of time to write in the exam. So let's just be sharp, let's be fast, let's be good. Okay. So most common is pre-renal. First thing. In that, most common is ATN. Okay. ATN is most common, followed by prenatal. Prenatal, what do you have? Hyperperfusion. Okay, hyperperfusion can be can occur due to hypovolemia, congestive cardiac failure, congestive hepatomegaly, NSAIDs, ACRB, ARB, which fucks up the autoregulation of the kidney. Now, kidney intrinsically we can have tubules, we can have glomerulus. In tubules, we can have glomerular nephritis, we can have lupus, good passion, any shit you can write. Okay. In uh, renal, we also have acute tubular necrosis. Acute tubular necrosis happens to be the most common cause. It's the most common cause of this one. Okay, an acute tubular injury occurs more commonly due to ischemia of any cause, but acute is post-renal. We have these include obstruction of the urinary tract at any point in its course from the tubule to the urethra. Okay, obstruction of the flow of urine. Okay, then we have increased renal venous pressure. It's seen in heart failure with preserved ejection fraction and abdominal compartment syndrome. What happens here? Renal venous pressure is increased. Okay. So pre-renal, we had hypovolemia, cardiac failure, congestive cardiac failure, vasoocclusion, NSAIDs, ARB, which increases vasoresistance. In renal, we had glomerular and tubular. In tubular, most common acute tubular necrosis, acute tubular nephritis, acute tubular necrosis, most common. Okay, think back. Acute tubular necrosis. It's the most common cause. Okay, then these include obstruction of the urinary tract at any point in its course from the tubule to the urethra. Fine. Post-renal is anywhere obstruction. So this much is understood. Etiology we got. Next we go for a bit of explanation.